study is outcomes of deep anterior lamellar keratoplasty by big bubble technique. As you all know, keratoplasty has been the gold standard for treating corneal blindness, but there are certain disadvantages attached to it, like risk of endothelial rejection, post-op recovery is lower, and need long-term steroid application. Now DARC is a newer variant where we remove the diseased anterior layers of the cornea and retain the healthy innermost layer. Here, there is no risk of endothelial graft rejection. Donor cornea tissue selection is less stringent, and if the graft fails, we can always go in for a repeat penetrating keratoplasty. With inability to obtain a smooth surface, leading on to a poor quality of vision. The deepest and most desirable plane is obtained by big bubble by Anwar. Here, air is injected into the stroma with a 27 gauge which forms a big bubble between the decimal membrane and the stroma, leading onto a clean cleavage line that aid in dissection. Excuse me, the video is not. Inclusion criteria was keratoconus and patients with anterior stromal pathologies like macula and granular corneal dystrophy, anterior stromal scars. Exclusion criteria was patient who had intraoperative perforation and had to be converted to penetrating keratoplasty, less than 6 months follow-up, endothelial dysfunction, and diseases like glaucoma, amblyopia, and retinal diseases. Pre-op evaluation included uncorrected and best corrected visual acuity, manifest refraction, slit lamp biomicroscopy, tonometry, dilated fundoscopy. 16 eyes of 15 consecutive patients were taken up, and all the surgeries were performed by a single surgeon. The center of the cornea is marked, and after partial trephination, the air bubble is injected. The superficial layers are removed, and you can see the clear endothelium beneath it. The endothelium from the donor tissue is removed and secured onto the stromal bed with 10-0 nylon 16 interrupted sutures. The selective suture removal was started at 3 months after the surgery based on the corneal topography. Outcome measures were uncorrected and best corrected visual acuity, post-op endothelial count, intra and post-op complication, surgically induced astigmatism. Follow-up was at first day, first week, 1 month, 4 months, 6 months, and 1 year. Analysis was done by SPSS statistical software. Sex distribution, male and females were equally distributed. Age group of the patient was more mainly from the 20 to 30 age group. Left eye was more predominantly involved, and the donor tissue came from the 60 to 70 group. The quality of tissue was mostly good, and preservation time ranged from 16 to 92 hours. Indication of the surgery was keratoconus. A major indication was keratoconus. The mean pre-op visual acuity at the start was 1.627, and the visual acuity at 1 year was 0.376, and the difference between the two was statistically significant. The mean spherical equivalent at the end of the study was 2.9, mean astigmatism was 3.8. Complication encountered were double anterior chamber, shallow anterior chamber, both resolved with conservative management. Steroid-induced IOP rise in 5 patients, which also resolved with topical anti-glaucoma medication. Graft failure in 1 patient, interface A's in 4, loose sutures in 2. The average endothelial count at the end of the study was 2,343. Visual acuity of 20/40 or better was seen in 63.75% of cases. Visual acuity of 20/20 or better in 12.5% of patients, which is comparable to the Anwar study. 3 patients had vision less than 618, of which 1 had graft failure and 2 had interface haze. 6 patients had microperforation, of which 1 went on to have graft rejection and 1 had a visual acuity of 624, others were better. Visual acuity in patient who had achieved big bubble was 0.2886, and visual acuity in patients without big bubble was 0.639, and the difference was statistically significant. We found that the mean post-operative cylindrical refractive error and mean spherical equivalent in our study was comparable to the other similar studies. Big bubble was achieved in 75% of cases, which is also comparable. Limitation of our study was a small sample size, short follow-up period, and inability to record the pre-op endothelial count. So the interpretation from this study is a DARC by big bubble technique is a valuable treatment in anterior corneal pathologies. And visual outcome here is good when exposure of decimal membrane was achieved with big bubble. But because of advantages of DALK in elimination of endothelial graft rejection, less stringent follow-up care, better utilization of tissues, it can be considered as a first surgical option in patients with keratoconus, corneal stromal pathologies with normal endothelium. Thank you.